Hi everyone, my name is Natalie. I am the oncology pharmacy resident here at Monument Health Cancer Care Institute, and for my clinical pearl for this month, I am looking at the Bruton tyrosine kinase or BTK inhibitor class, and we did see a new approval in January of 2023 with this medication class, so I wanted to delve a little bit more into the differences between covalent versus non-covalent BTK inhibitors. My objectives for this presentation are to provide a brief overview of mantle cell lymphoma, which is our current approval for the newest BTK inhibitor. I also want to describe the B-cell receptor signaling pathway and where the Bruton tyrosine kinase fits in that pathway, and then talk about the differences between the covalent and non-covalent BTK inhibitors and also their potential risk for development of resistance. And then finally, I will talk about the Bruin Trial, which is the trial leading to the approval of Pirtobrutinib, our newest BTK inhibitor for relapsed or refractory mantle cell lymphoma. So first, jumping into an overview of mantle cell lymphoma. So mantle cell is a type of non-Hodgkin lymphoma, which represents a really diverse group of lymphoproliferative disorders. 85% of them are going to be a B-cell lymphoma, but we can also see T lymphocyte as well as very rarely natural killer cells. Mantle cell is challenging in that it incorporates characteristics of both our indolent as well as our aggressive non-Hodgkin lymphoma subtypes. So like indolent lymphomas, it typically has a less response to traditional chemotherapy, but then also in contrast to our indolent lymphomas has a more aggressive disease course. It is characterized by translocation of chromosome 11 and 14, and this causes a translocation of the cyclin D1 locus and the immunoglobulin heavy chain or IgH gene locus that causes an overexpression of cyclin D1. And cyclin D1 is a cell cycle regulatory protein that's essential for transitioning the cell from the G1 to the S phase of the cell cycle. This is just a summary table of the breakdown of the types of non-Hodgkin lymphoma, looking at categorization by indolent, aggressive, or very aggressive. So our more aggressive lymphomas typically do have a better response to chemotherapy due to their higher proliferation rate, but then a decreased overall untreated survival, in contrast to our more indolent lymphomas where they have a poorer response to chemotherapy but a prolonged untreated survival. And as I mentioned, we do see that mantle cell falls into that more aggressive category. For epidemiology, mantle cell is actually one of our more rare types of non-Hodgkin lymphoma. So only about 3% of patients are diagnosed annually, so about 1 in 200,000 individuals. And for the median age, it is more common in our older adult population, so mid-60s is median age at diagnosis, and then much more prevalent in males, a 2-to-1 predominance. There are certain familial risk factors that can be associated, particularly with earlier onset of mantle cell lymphoma, and in particular, we can see germline variations in our mismatch repair pathway. For diagnosis of mantle cell, immunohistochemistry can be helpful for histology, so looking at cyclin D1 overexpression, and then SOX11, which is a transcription factor, is also very commonly overexpressed in mantle cell, regardless of cyclin D1 expression. FISH testing can be used for the translocation of 11 and 14. And then we do see the TP53 mutation is associated with a poor prognosis, even among patients who undergo stem cell transplant. In contrast, the immunoglobulin heavy chain variable, or IgHV mutation, is actually associated with a better prognosis and more indolent disease course. We do also have the use of the Mantle Cell Lymphoma International Prognostic Index, or MIPI score, and this has been associated with median overall survival. So patients with a low-risk MIPI score, their median overall survival is not reached. In comparison to those with a high-risk MIPI score, median overall survival is approximately 29 months. Our clinical presentation with mantle cell lymphoma can be variable. Patients do often present with B symptoms such as fatigue, night sweats, and weight loss. But we can also see bulky nodal as well as non-nodal involvement, including central nervous system, GI tract, spleen, tonsils, as well as bone marrow involvement. On the other hand, patients may be asymptomatic and they may have, incidental findings on routine lab work that leads to the diagnosis. For treatment, in our favorite guidelines, they do discuss a variety of more intensive and less intensive induction chemotherapy regimens for treatment, and then we do see our addition of BTK inhibitors for use for maintenance therapy. So recommended maintenance therapy is 2 years with our covalent BTK inhibitors, including ibrutinib, acalabrutinib, or zanubrutinib. And then for second-line therapy, they recommend use of a covalent BTK inhibitor continuously. And then for third-line or subsequent therapy, we do see finally our use of our newest BTK inhibitor, Pirtobrutinib, which is a non-covalent BTK inhibitor that I'll be talking more about. I first wanted to talk a little bit about BTK inhibitors and their background in general. So the BTK inhibitors are involved in the B-cell receptor signaling pathway, and this is important for the development and proliferation of both normal and malignant B cells. And we do see that abnormalities in this cell signaling pathway are responsible for a variety of B-cell malignancies, including CLL, marginal zone, Waldenstrom, and mantle cell lymphoma as well. So this diagram of the actual cell signaling pathway, I think, is helpful. As you can see, the B-cell receptor is a cell surface receptor and is triggered by extracellular binding of an antigen and then triggering this intracellular cascade, ultimately leading to production of transcription factors. And you can see the Bruton tyrosine kinase, or BTK, is very centrally involved in that cell signaling pathway. The Bruton tyrosine kinase is a cytoplasmatic kinase, and it was actually interestingly first discovered in the early 1990s with research that was ongoing looking at genetic causes for X-linked agammaglobulinemia, which is found almost exclusively in males since it's an X-linked genetic disorder. And it is caused by a mutation in the Bruton tyrosine kinase where there's this disruption in the B-cell development, and patients experience a dangerously low immunoglobulin production. The B-cell receptor is expressed by hematopoietic and plasma cells, especially B lymphocytes, but can also be involved in secretion of cytokines and histamine, so more of our inflammatory cascade. So by inhibiting the Bruton tyrosine kinase, we are blocking the downstream signaling that's thought to be responsible for the development of B-cell malignancies, but also autoimmune disorders with that association with inflammatory mediators. And as I mentioned, we do have two broad categories of BTK inhibitors. We have our traditional agents, I guess I'll call them that, which are irreversible or covalent inhibitors. And then we have our newest agent, the reversible or non-covalent BTK inhibitor. So this is just looking at our current drug therapy options for BTK inhibitors. So again, ibrutinib, acalabrutinib, and zanubrutinib are all considered our covalent or irreversible inhibitors. Ibrutinib, first released in 2013, is actually one of the top 5 selling drugs in the world, but we do see some concern for off-target effects with ibrutinib, particularly an increased risk for bleeding and hemorrhage, as well as cardiac arrhythmias. So with acalabrutinib and zanubrutinib, there were some particularly pharmacokinetic improvements with the BID dosing thought to have the ability to achieve a higher plasma concentration. And then also zanubrutinib has a longer half-life than acalabrutinib. And then we do see pirtobrutinib approved just in January, as I mentioned, currently approved for relapsed or refractory mantle cell lymphoma. Wanted to highlight some of the pharmacokinetic differences with these agents, and in particular really focus on the binding site for our 4 different agents. So the covalent BTK inhibitors are all going to bind to the same active site in that Bruton tyrosine kinase, which is this cysteine 481 residue, in contrast to pirtobrutinib, which binds to a completely different site, the ATP binding site. I also wanted to point out some of the differences in terms of bioavailability and half-life. So our covalent BTK inhibitors are highly bound to plasma protein, and then you can also see they have a relatively short half-life. And so there is some thought that due to those issues, there is actually a relatively short window of time for the drug to reach its target and cause inhibition of that kinase. So in contrast, we do see that Pirtobrutinib has a much higher bioavailability as well as a significantly longer half-life than our other agents. In terms of dosing, as I mentioned already, Acalabrutinib and Zanubrutinib with that BID dosing thought to achieve much higher plasma concentrations. For severe renal impairment, not data for use with these agents, and then there are recommendations for mild to moderate hepatic impairment. For adverse effects, we do see cytopenias such as thrombocytopenia, neutropenia that can develop. Also risk for skin rash and musculoskeletal pain and upper respiratory tract infections. So this does cause some class side effects that can be associated with all BTK inhibitors, and some of these are thought to be due to actually off-target effects. So particularly like skin rash and GI side effects are thought to be due to an off-target effect on the epidermal growth factor receptor causing those side effects. In contrast, the risk for bleeding is thought to be due to an on-target effect due to downstream inhibition of platelet aggregation. So it is recommended to hold all of these agents prior to elective surgeries due to that risk for bleeding. As I mentioned, Ibrutinib thought to be a little, have less selectivity for that kinase, so is associated with some off-target effects such as increased risk for cardiac arrhythmia, such as atrial fibrillation. And many of the studies with the BTK inhibitors did exclude patients that were receiving warfarin for treatment of atrial fibrillation. I next wanted to talk a little bit about the resistance mechanisms that can develop with the BTK inhibitors. And as we've already talked about, the binding site for the BTK inhibitors is very, very integral to the risk for resistance with BTK inhibitors. So as we saw, all of our covalent BTK inhibitors do bind to that same cysteine 481 residue and prevent that catalytic activity of the kinase. But we can see resistance can develop in many patients due to a mutation at that site where there's a conversion from cysteine to serine, and that can interfere with the ability of the BTK inhibitor to bind, and then we have restoration of that catalytic activity and restoration of that abnormal cell signaling pathway. In contrast, our non-covalent or reversible BTK inhibitor, Pirtobrutinib, has been developed to, number one, have some improved pharmacologic properties, again, with that improved bioavailability and improved half-life. But I think most importantly, it also has that ability to maintain activity against the BTK that has mutations at that cysteine 481 site, since it does not require binding to that active site. And I think it's just interesting to note, so like Ibrutinib, we did see released in 2013, and we did see our first reports of resistance with Ibrutinib that came about in 2014. So relatively short window for development of resistance with these agents. I wanted to talk a little bit more about specific B-cell resistance mechanisms. And most commonly, disease progression is going to be the reason for discontinuation of the BTK inhibitor, and that disease progression can be due to, in certain cases, a Richter's transformation to actual diffuse large B-cell lymphoma, but more commonly is going to be related to that secondary resistance where there's a change in that binding site. So up to 80% of patients with ibrutinib resistance will have a BTK mutation. So again, I think very appealing place in therapy for our new BTK inhibitor to potentially be used for patients that have disease progression due to a potential mutation. So that brings me to the Bruin Trial, which led to the approval of Pirtobrutinib. This was published in Lancet in 2021. This is a phase 1 and 2 study looking at Pirtobrutinib in a variety of B-cell malignancies. So this was the first in human multicenter open label phase 1 and 2 trial. Phase 1 was a dose finding portion of the study looking at 7 different dose levels of Pirtobrutinib given on 28-day cycles. And then phase 2, patients were stratified into 6 different cohorts based on the type of B-cell malignancy, the prior therapy, and then testing for their BTK mutational status. For inclusion criteria, they looked at patients with confirmed B-cell malignancy who had received prior treatment with at least 2 lines of therapy, although there was a protocol amendment during the study where they did allow patients with CLL to be included if they'd received at least 1 prior line of therapy. They did allow anticoagulants and antiplatelet therapy, except warfarin, for patients that were being treated for controlled atrial fibrillation. For primary endpoints in the phase 1 portion of the study, they were looking at that maximum tolerated dose and then really trying to determine what would be their recommended phase 2 dose of Pirtobrutinib. For secondary outcomes, they looked at overall response rate as well as pharmacokinetic and safety data. For the phase 2 portion, they looked at their overall response rate and then a variety of secondary outcomes, which did include progression-free survival, overall survival, and safety data. For statistical methods, so their data endpoint was September of 2020. And for the phase 1 portion of the trial, they required 3 to 6 patients per each cohort for their dose finding portion. So up to 150 patients were permitted across all dose cohorts. And then in phase 2, they permitted 20 patients per cohort, assuming that there would be a response rate of at least 30% to provide an 89% probability of having at least 4 responders. For safety analysis, this was conducted in all patients that had received at least 1 dose of Pirtobrutinib. So looking at the patient demographics here, just wanted to point out that they did randomize 323 patients, but as I mentioned, there were a variety of B-cell malignancies. So actually most common was CLL, and then Mantle Cell lymphoma was represented by 61 patients. But you can see that majority of them had received a prior BTK inhibitor, so 93% in the Mantle Cell lymphoma group. Relatively low number had received a BCL2 inhibitor like venetoclax, only 15%. And then in terms of reason for discontinuation, as we discussed earlier, most commonly that was due to progressive disease, so 77% in the Mantle Cell lymphoma group. For high-risk cytogenetics, which was only evaluated in the CLL group, they did see 25% had the 17p deletion, 30% with the TP53 mutation, 11q and 19%, and then an unmutated IGHV in 88% of patients. And that actually is a higher number than expected, and again confers a poorer prognosis generally. So in literature, typically that incidence has been only 40 to 50%. And then looking at their consort diagrams, so you can see that a total of 323 patients were included in their safety population, and then 269 were considered evaluable for efficacy. And looking at their rates of discontinuation, 86% did discontinue treatment during the study, but a majority of those, 66 patients, were due to progressive disease. So looking at the results for efficacy in the phase 1, they did show that Pirtobrutinib exhibited linear pharmacokinetics across all dose levels, so between 25 and 300 milligrams, and there were no dose-limiting toxicities that were observed. So when it came to the phase 2 portion of the trial, efficacy would support the maximum 300 milligram dose, but they actually did see that the 200 milligram dose, there was 96% target inhibition of that Bruton tyrosine kinase, so the 200 milligrams was their recommended phase 2 dose. For their phase 2 portion of the trial, they did show an overall response rate of 63%, and again, this was in 139 patients, evaluable patients with CLL. Did include a high percentage of partial response in 69 patients, as well as stable disease in 45 patients. They also looked at specifically the 121 patients who had been pretreated with the BTK inhibitor and showed a very similar overall response rate of 62%. And then when they looked at the BTK mutational status, so looking at that cysteine 481 mutation, they did show a slightly higher overall response rate of 75% in patients that did exhibit that mutation in comparison to 60% who did not have the mutation. At a median follow-up of 6 months, 88% of patients with CLL were continued on therapy, and the longest follow-up to date has been just under 18 months. So looking at the Kaplan-Meier curves, so this is on the left-hand side, we see the response rate in CLL, and then the right-hand graph is the mantle cell lymphoma population, which is again our current approval for Pirtobrutinib. In terms of safety data with Pirtobrutinib, majority of adverse events were low grade, so 87% were considered grade 1 or grade 2. Most commonly, these were fatigue, diarrhea, or contusion or bruising. And then grade 3 or 4 events were more common with neutropenia as well as febrile neutropenia, but this risk for febrile neutropenia did not appear to be a dose-dependent risk. And then along with that, there was an increased risk for upper respiratory tract infections. In terms of risk for cardiac arrhythmias, they were reported in 2 patients in this study, so less than 1%, and they were considered grade 2 for both events and unrelated to Pirtobrutinib. There was 1 instance of a grade 3 hemorrhage in a patient, and that was related to trauma. So it was a subarachnoid bleed following a bicycle accident. I think it's interesting to note among the patients that had discontinued their prior BTK inhibitor therapy due to either cardiovascular toxicity, which was 15 patients, or hemorrhage, which was 3 patients, there was no recurrence of either of these side effects noted with Pirtobrutinib. So for discussion and conclusions, the authors did determine that Pirtobrutinib is a highly selective and first-in-class reversible BTK inhibitor that does show efficacy in a variety of B-cell malignancies. So particularly in the CLL space, the role in therapy after failure of a traditional covalent BTK inhibitor or a BCL2 inhibitor. And we do see Pirtobrutinib listed in the CLL guidelines, just does not have the FDA approval yet. But in comparison to venetoclax, Pirtobrutinib does not require any ramp-up dosing, but certainly longer follow-up is necessary to, assess this efficacy and safety, especially considering the prolonged course for many of these B-cell malignancies. For safety, they did show that Pirtobrutinib was well tolerated across a variety of doses. So again, no maximal dose was identified in that phase 1 portion. And they did see a low rate of our cardiac arrhythmias or bleeding to date, but they did exclude patients that received warfarin, although they did permit other anticoagulants and antiplatelet agents. And again, the risk for contusion is really a class effect of all BTK inhibitors and thought to be due to an on-target effect of that downstream platelet aggregation. So for future directions, there is a phase 3 Bruin trial that is currently recruiting, and this will be a head-to-head superiority trial looking at Pirtobrutinib in comparison to all 3 of our covalent BTK inhibitors. And this will be looking at previously treated but BTK inhibitor naive patients with mantle cell lymphoma. So in summary, the B-cell receptor signaling pathway is essential for the development of both normal and malignant B cells, and we do see that abnormalities in this cell signaling pathway can cause a variety of B-cell malignancies, and the Bruton tyrosine kinase is an essential step in this pathway. Non-Hodgkin lymphoma is a diverse group of lymphoproliferative disorders, with B-cell representing almost 85% of cases. Mantle cell lymphoma is a relatively rare subtype of non-Hodgkin lymphoma, so only about 3% of all newly diagnosed cases. High male predominance and typically is challenging for treatment due to a more aggressive disease course as well as a poorer response to traditional chemotherapy. The BTK inhibitors block the downstream signaling that's necessary for the production of malignant B cells, and so our current agents, our covalent agents, include ibrutinib, acalabrutinib, and zanubrutinib, but we do have this new non-covalent reversible agent with Pirtobrutinib, and it's currently approved for relapsed or refractory mantle cell lymphoma. and typical standard treatment for mantle cell lymphoma, and is involved with induction chemotherapy followed by maintenance therapy with a covalent BTK inhibitor. Currently, Pirtobrutinib is approved as third-line therapy based on the phase 1 and 2 Bruin trial, and I think most notably, it has the ability to overcome the resistance mechanisms to our covalent BTK inhibitors that can be caused by mutations in that cysteine binding site. So I think it will be very interesting to see the place in therapy for Pirtobrutinib going forward and with further research. So here are my references, and thank you so much for listening to my clinical pearl.